just leave it off for the moment. We're going to just vacuum on. Fine? Yep.
Okay,
Yep.
so let's have a look. He's been anaesthetised, it's under GA. We have a hard board with a vacuum mattress just to immobilise him in place. We have turned him ever so slightly left side down, right side up, because it's a posterior lesion, and I think that the angle that will be needed will be aiming directionally downwards, so I want enough room and enough space to get that in. And the next thing we're going to do now is just to work out where the stereotactic markers are going to go. So we need these to be in a position where the video camera on the CAS-One device on the CAS-One device will see them, but they won't interfere with the trajectory of the planned needle. So something like this, slowly rotated around, will be suitable. We use the template aiming device to draw on the patient's skin with a skin marker. In our practice, we've found that the most efficient way to do it is to have the anaesthetic machine to the patient's right and the anaesthetic circuit running through the top, through the CT gantry, such that nothing else is in the way or interfering. Patient is now prepped and draped. Next step is to put the stereotactic markers, skin markers on. You don't always need to use all 6, but as best practice it would be best to try and get them all in view and visible. So we now have the 6 markers on, and the next step then will be to do a CT scan and see whether or not we can identify the tumour. The first thing we have to do here is we have to load in the patient's CT scan so we can see what it is we're dealing with. We have the facility now just to specify exactly what it is we're doing. We've put liver, HCC and ablation. We're going to use the angiodynamic Solero probe. By defining that, it means in the background the segmentation process will now proceed, and that's indicated by the flashing light that we see here on the left of screen. So what we'll be looking to do now is to start the planning process, and we'll do this by drawing on the tumour and trying to just define a rough entry point, which may be something along these lines here. Using the auto segmentation process, the tumour will be segmented. In the meantime, what we'll be looking to do is to pick our selection probe. So we've got what looks to me, just by visual inspection, a good outline of the tumour. We can see the red circle outlining the tumour, and we can see the margin around it, which is adjustable, which I typically set to 5 millimeters for an HCC. So we've got the microwave probe set up here. What we will do now is just simulate what it would look like with a 140 watt burn for 2 minutes. And we can see the green circle shows that and comfortably covers both the tumour and the margin. If we go to the other screen now, there is a relatively small branch that may be potentially injured by the route that has been planned. So this is an example now where I might look to just slightly change the entry point, perhaps to something a little bit more vertical. What we will now see is that we're missing those branches and heading for the tumour there without injuring any significant vascular structure. Now what we take is the aiming device, which has already got the stereotactic reflective markers attached, and we can kind of see what it's going to look like with different routes that we have planned and where our skin entry point is likely to be. Quite helpfully, it tells us in the bottom left corner of the main screen what the trajectory length is likely to be, which might be, in this case, about 16 centimeters. We'll put together the aiming device. And once we've put that together, we'll put the reflective stereotactic markers on the 3 prongs here. So we now have an aiming device with stereotactic markers on. This is the mechanical arm that is going to attach to the patient. This will attach to the board on the side of the bed, and our actual aiming piece of equipment, which is here, needs to be connected onto this piece here. And we can see the arrows on these, and these need to be aligned so that the trajectory is kind of zeroed, so we're able to adjust that from a consistent starting position. And there's a further set of arrows here, which is controlled by this one, and once again these also need to be aligned, which they are now. So this is where the needle and aiming device is going to go in here. I'm just looking again at the entry point. You can see that I'm quite close to a rib there, so again, slightly want to adjust that. I planned a trajectory here, and I'm just repositioning the needle to make sure I'm 100% happy I've got a shorter, or the shortest possible trajectory I can get without hitting any key structures. So I think I'm happy here. Can we just hold breathing, please? So just on a breath hold, I position the little circle first, and then I'll just tweak. I'll just tweak that into there. Right, so that's pretty good there. So I'll just check again that I'm happy, I'm not hitting anything important, not going through any structures, either vascular or bony. I'm away from the pleura, so having the lungs potentially visible is also useful. Okay, so 16.7. 16.7. Breathing on, please, thanks. I think we're happy with that. That's good. So we're now ready to position the probe, to put the actual probe in. We know it's 16.7 centimeters. That will be from this surface here, which is where we've measured with the aiming device. And we know we have the markers on the antenna to tell us how far to go in. So 16.7 is there. We'll be putting this in on a breath hold. Depending on the sharpness of your needle or antenna, you may need to make a skin nick. With this particular device, you usually don't. Can we just hold breathing, please? And breathing on, please. Thank you. So we've now got a needle verification scan, and what we can see here is part red, part green. The red is the original CT scan we did, and the green is the one we've just done after we've put the needle in. What I'm looking for on the 50-50 scan is I'm looking for, is there any significant evidence of motion in between the two? So do you see the red and the green separately around the edge of the liver? And in this case, there's very good control, and we don't really see any significant movement in between the two scans, which is fantastic for us. So we go to the next one, and we go to verify, and we go to a run detection thing, and we can see that on the latest scan, here is the needle, and it's pretty good, really, when all is said and done. It's close to what we planned, and over here we've got a representation of where we are. It says that our lateral deviation is about 6 millimeters, and you can see that there, and the depth is about 1.5 millimeters too short, so not too bad. The good thing about microwave is that you can always, if you're worried a bit about the lateral margin, you can just change the size of your ablation zone and to make sure that you get it all, which I think we will here. Over on this screen we have the down the needle view. I think it's pretty close, and I'm reasonably happy with that. Okay, can we go 140 watts? Because of the lateral deviation, I'm going to set it to 3 minutes rather than 2 minutes. Okay, you happy, David? Okay, so we're going to track ablate now. So track should be, if you give me about 20 seconds, I'd say. Can we have a breath hold, please? 100, yeah, 20 seconds. Go, start. And stop. Okay, so we're going to do another CT scan now to check what we've burnt.
Okay, breathing back on, please.
Okay, so once again, we're looking for the image fusion now between the first and the second. Minimal amount of movement, usually looking for the diaphragm edge in the lung. So that looks okay. We'll go to our assessment, and it's found us what it thinks is a reasonable seed point. And we'll let it segment. The new artificial intelligence features enable much better segmentation than was previously possible. It's kind of thinking about that. And what we're seeing there is actually a really, really effective result. What we have on the right-hand side is our coverage compared to our original tumour. We see the green circle being the ablation zone, and we are now seeing tumour coverage at 100% and margin coverage at 90%. Everything is to the right of the red line, which I like to see. We can see the tumour, which was here, has clearly been covered by the ablation zone. And so even though it's a subcapsular lesion, which means that you lose some, you're unable to measure the margin right around the edge of the subcapsular zone, but actually this looks to be a very good result, and I think we're happy with that. So I think we can stop there. I don't see that there's another need to do any further ablation. It's a bit of local anaesthetic. Should say again that the effectiveness of this whole procedure is such that it's actually hard to see where you've made a mark on the patient, but it's down here. I've actually caused more bleeding through giving the anaesthetic than through the actual procedure itself.